Welcome everyone to today's Executive Roundtable, Data and Disruptors, 3 companies harnessing the positive power of data during transformative times. I am Ayla Ellison with Becker's Hospital Review. This roundtable is a part of the Becker's Health IT and Revenue Cycle Management virtual conference. During today's session, we invite you to post questions, give insights, and submit feedback via the Q&A box on your screen. We will try to address as many of your submissions as we can, as we have time for today. We will also have a series of polling questions during today's roundtable. When we reach each poll slide, the poll question will pop up automatically on your screen. Our moderator will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's roundtable to access the recording. At this time, it is now my pleasure to start today's roundtable by turning the floor over to Jim Bonesock with TransUnion.
Thank you, Ayla. We appreciate the opportunity and welcome and thank you to all of our attendees today. TransUnion Healthcare is really excited to sponsor this roundtable today. We're thrilled to have with us a couple of our partners to share with you some of their awesome stories of how we at TransUnion are using what we call information for good. For me, I've been in this crazy, ever-changing and fun healthcare industry my entire life and career, and I'm currently serving in the leading growth and strategy for healthcare here at TransUnion. The good news about that is it allows me to work with some of these amazing partners that we have and to leverage the data and the assets and the power of TransUnion to help, in our way, change kind of the healthcare landscape and improve the health and wellness for individuals. Many of you probably know TransUnion as one of the 3 credit bureaus. Right, along with Experian and Equifax, that is in fact where we got started. But while that is true, we're actually much more than that. So we like to refer to ourselves as an information and insights company. Why that's important to this is that we're the only company out there today that possesses both credit and public record data sets. So on one side, as I mentioned, you have the TransUnion, Experian, and Equifax group of companies that play in this very highly regulated credit bureau environment. And on the other side, you have the folks like LexisNexis and Thomson Reuters, Wolters Kluwer, who play in the public record kind of data assets. So what does that mean? As you look at this slide, we've got over 65 petabytes of live data on individuals and communities, growing roughly 20% year over year. When you talk about big data, we've got it. And what does that mean? For us, it means that we know a lot of things about a lot of people, around consumers, around patients, around the health plan members, your employees, and the communities in which they live. It also means that we can use that data in combination with other healthcare data assets, claims, clinical data, membership data, to improve efficiency and effectiveness in the healthcare market. And it means that we can paint a more informed picture to improve the health, the wellness, and the lives that we touch. It really matters in healthcare. There's so many aspects, as you can appreciate, of a person's life, as we know from discussions around social determinants of health, that influence their health and wellness and the ultimate outcome. COVID has, by itself, demonstrated that and exposed the flaws in both the healthcare industry and our society kind of in general, and the pressures on which those kind of environmental factors begin to play. Finally, as we do know that, healthcare and healthcare debt and the financial pressures that are applied when people unwillingly end up in a situation where they need to access healthcare services cause bankruptcy at the highest level of any other cause for individuals. With that, I want to get to our awesome partners that are here with us today. I'm very thankful for the relationships we have and the work we get to do with these guys every day. First, let me start with Dr. Trina Williams, who is a former practicing family physician and an entrepreneur, one who I got to know our days at Deloitte and have been friends and colleagues ever since. After building his first company, Clinovations, he sold it to the advisory board company. He started the current company, Socially Determined. Socially Determined, he'll get more into, it was purposely built around technology to address social determinants of health. Next, we've got Joe Gonzalez, who's the co-founder of CLX Health. Joe's been a lifelong healthcare person himself, an innovator, and spends his time thinking about how do I leverage and move this data within the healthcare environment. Joe has partnered with TransUnion to create an application in the midst of this pandemic to help people begin to move about more freely. How do we leverage clinical lab orders and results data in combination with identity data and give it to individuals, give it to companies, give it to other organizations so that people can begin to interact in a more comfortable way, knowing that I've tested negative, I've got the immunization, that kind of thing. How do we make that actionable? And so Joe and CLX Health have done some very interesting things to help us try to get back to work, to try to get back to travel, to try to get us back to life in general. And then last, and certainly not least, Craig Antico, who co-founded RIP Medical Debt. You know, as a career-long executive in the collections industry space, Craig and his team sought out a better way to address the challenges that are posed by healthcare debt on individuals. And as a not-for-profit, Craig is able to partner with donors to purchase that charged-off debt and eliminate people's medical debt obligations. And to date, they've wiped out over $2.5 billion of medical debt. So an incredibly cool way to use data. All of these collectively, as I said, we're partnering with on our effort to use information for good. So before we get into the questions for the audience, there's a polling question up on your screen today. And we want to just get a quick sense for those that are attending today versus those that registered and maybe couldn't attend. At a high level, who do you work for? Or what's your perspective coming into this roundtable? You can take a second to let us know if you're with a healthcare provider, including ambulatory physician practice specialty or other. Are you working for a payer, health plan, managed care organization? Do you work for a life sciences company, pharmaceutical, biopharma, other, or is it in fact other? I don't work for any of those. Give you guys a second here to answer. Who we've got. So the majority of you, not surprisingly, work for a healthcare provider. We don't have anybody from a health plan perspective. And we've got some life sciences company and other. We'll have to get into what other looks like. We've kind of got an understanding of where you work. Our second quick question is, what do you do there? What's your perspective? What are the things you think about there? Are you in a finance kind of revenue cycle function? Are you in IT? Are you a clinician and or in clinical delivery? Do you work in general operations? Do you focus on building products? Or none of the above is the other category. So pause for a second there, see if we can get some answers on this one and look at pretty good spread of finance, IT, clinical delivery. It's across the board. So great. Pretty equal spread, hopefully something in this presentation and roundtable for everybody. Let me turn now to our panelists. And I want to start here with Craig. Craig, can you give us more on how specifically your organization uses data to do what you do?
Sure. We use data for several parts of our business or our charity. One, we use it to price a portfolio when we go to buy it from a hospital or a doctor's group. Second, we use it to qualify which patients are a charitable class. It's usually very similar to what a hospital would have in their financial assistance policy. So we use data for that. We also use data to target groups of people. For example, we have a Helping COVID Heroes fund that we've raised over $1 million, where we use TransUnion to identify out of the portfolios of debt that we have to buy, which people are first responders, nurses, EMT, all these different people. Then we use another part of their data to identify the occupations that are being hard hit. We've identified those. So that's another type of approach. And then the third or the fourth way is that after we abolish the debt, we'd like to know the social determinants of the debt that we've abolished. So we've abolished debt for 1.8 million people. We want to know, well, what was the predominant issue? We know that oftentimes it is a financial insecurity, but was it also social isolation? Was it food desert, things like that? And then we also use data, there's a lot of data here. We also use data to find out what was the race or ethnicity of the people that we abolished the debt for. We don't target it that way, but we do in a retrospective look at the data and see, what people are being missed on the first safety net as we're the second safety net for the healthcare systems.
Awesome. I love the RIP medical debt story. Joe, similar question for you. You guys are, as Craig talked about, kind of a COVID impact there and a COVID approach.
Yeah.
Can you tell us more about kind of what CLX is doing?
Sure. So CLX as a foundation of the platform is a clinical exchange. So we move lab transactions between providers and laboratories. That was a pre-COVID world and still very much a COVID world. But we look at our environment among three stakeholders as far as leveraging the data that we have. Our first client, if you will, is the health plan. The health plan has different use cases within it, but the primary driver from a health plan perspective in this COVID environment is focused on managing and maintaining those in-network relationships between their members and those laboratories to make sure that they're managing their costs and keeping their members in those network relationships where they have access to the greatest amount of data to better manage the patient/member experience. Then we look at it in our health system customers where they're actually employing our services or using our services in how they manage their own employees and visitors. So within our application, we're able to manage and create parameters around testing. So now if a health system has an employee that they're requiring testing from every 3 or 5 days, whatever that cadence is, we can manage that, geofence that location through our application and make sure that once they've entered that geolocation, that they've met the criteria to be able to enter a facility, and all that information is auditable by human resources and other personnel and management to make sure that they're creating a safe work environment for the other employees there, as well as the patients who've come in to be treated. And then finally, our other major client are the laboratories. And the way our platform manages capacity in this COVID world is really understanding the metrics and the turnaround times and how long it takes for a result to come back. And that's really helped our consumer customers, but more so from a laboratory perspective, giving them the options and opportunity to be able to manage their business effectively, because they can track and also give back in real time what their capacity availability is. No one wants to have what we all went through in the spring when you'd heard their stories of folks that were waiting 7, 10, 15 days for lab results. That whole experience was self-defeating around this COVID crisis. So that's really what we're doing and how we're leveraging our data for our different client bases.
So along those lines, you're delivering it a couple different ways, right? One is in a mobile application, right? So people can interact to schedule those tests, get those results back, and then share them, right, with individuals.
That's correct.
Companies.
That's correct.
Whoever,
so
right?
we've actually have two phases of our application. We have a web-based application where our providers, healthcare providers, and health systems interact with laboratories. And then on the consumer side, we have our mobile application, our Healthy America application, where the consumer can schedule their lab, their COVID tests. They have access to laboratories that are within our platform that we're connected to. They can select them based on location, based on turnaround time, perhaps even based on a relationship they have through their insurer. Schedule that test and then get those results back, and those are stored locally for them, but also within our Healthy America database for them to be able to recall, and it becomes a shareable document. It's credentialed by us. It's verified through their identity management tool that we are partnered with TransUnion on. And then they can, again, share that document as part of an employer-employee relationship or a consumer-to-business type relationship if it's needed for access to a facility or some type of engagement. And we're expanding that into travel with other partners as well.
I, for one, hope we can begin to leverage this to get back to our lives. Thanks for that, Joe. Certainly not least but last here is Dr. Williams. Same question for you. What's Socially Determined doing?
Well, first of all, Jim, thanks, and thanks to TransUnion and for Becker's for allowing us the opportunity to have this conversation. So really appreciate it, and honored to get a chance to present with Joe and Craig. The first thing I would say about data and sort of how we're approaching it, how the healthcare organizations that we're working with are approaching it, it starts with, I think, the recognition over the last number of years of what our public health officials, frankly, have been telling us for decades, is about the impact of social determinants of health or social risk on individuals and populations on their healthcare journey, right? And how it impacted where people go or where they don't go for care, the choices that people make when they fill their prescriptions, when they're able to follow a treatment regimen. And I think you pointed out, but I'll just highlight the impact of COVID and the social protests across the country have only highlighted the inequities that have persisted for decades and generations. And so what we believe and what we know from the data is that social risk, whether it's food insecurity or housing instability, financial strain, lack of transportation, health literacy issues, each of these individual factors, and collectively even greater, have a massive impact on care, on, again, where people go, on cost, clinical outcomes, on experience, measurable factors. So we have been able, over the last 4 years, to partner really broadly across the healthcare landscape with provider organizations, with health insurance companies, with life science companies as they think about clinical trial diversity and adherence, with state government agencies, both in the COVID crisis and before, as they think about their populations that they're responsible for, and even employers, as employers think, more and more self-insured, not just about healthcare costs, but the impact of social risk and social determinants of health across their employee population: absenteeism, presenteeism, productivity, and turnover. And so it turns out that social risk and social determinants of health are everywhere. In our risk-driven model, so we leverage data, and we'll talk about that maybe in a minute, to quantify social risk at a community level below the neighborhood level. So for every 200 meters across the United States, quantify social risk exposure in communities for food and housing and transportation, and do that same thing at the person level. So I know that Trenner Williams, what my risk is based on where I live, of food insecurity, which is a really good example when we think about that is partly dependent upon the assets and attributes of the community, right? Where there are healthy food options, where there's a grocery store, how many unhealthy options are around, and my own individual risk, which might have to do with family size, my economic makeup, my ability, right, for transportation and other factors like that. So utilizing those informations to identify and characterize social risk, then quantify, lay that information against a healthcare data set, so claims, utilization, disease, patterns, where people have gone, and be able to say, it looks like the diabetics who have food insecurity and housing instability do much worse clinically and financially than their counterparts who have diabetes but don't have those same social risks. Then help the organizations that we partner with prioritize, because there is no shortage of need. So help organizations use that data to prioritize where they can make the right investments and have the biggest impact. And then importantly and lastly, help them measure, and even during sort of mid-flight, measure the impact. And whether those are clinical outcomes or, again, financial PMPY, if you're a health plan, if you're looking at diabetics, you're measuring clinical markers like hemoglobin A1C. So measuring that impact and thinking about how you continually modify, bring the right people into those programs, and then scale across your populations.
You know how much I love SDOH stuff, so sticking on that for a second, the next kind of question for you. I know there are a multitude of examples, this SDOH world being, relatively new. There's certainly a buzz out in the market about its ability to be applied and people thinking about it.
Yep.
If we all can go back to HIMSS, SDOH will be on every, booth is out there for sure.
Right.
So it's getting the buzz. You guys have some real examples. Can you kind of help us understand kind of how you're creating that broader picture and for whom and, what that looks like?
Yep, sure. I'll give you a couple of examples. I'll start with the data real quick. So first of all, we are fortunate in 2020 and actually previously to have so much data available. So our challenge in this country is not the lack of data. The challenge is how do you find the meaningful data elements, combine them in thoughtful risk science, so data science-driven models to actually create risk indices and risk scores, right? So that it's not only about the data, it's not about data aggregation. It's about being able to quantify that impact. And so we work and pull in publicly available data from federal, state, local sources around those categorical areas like food and housing and economics. We partner with great organizations like TransUnion. And so where we have aggregate commercial data, maybe about credit scores, we've got consumer data and buying patterns. We have alternative risk, so financial, asset, legal, and other data to be able to paint a picture of somebody's life. When you combine public and commercial with the robust data that health systems and health plans have, so claims data, clinical data, disease burden, utilization pattern, and cost, you start to create a comprehensive picture. And from that, so a couple of examples with organizations that we've had the chance to work with. One of my favorites, I live in Washington, D.C. We partner with multiple entities, and I think that's one of the keys for success. So D.C. government, with one of the MCOs, AmeriHealth, with an unbelievable community-based organization, DC Greens, that's part of it, and a retailer in Giant Health, and 3 different federally qualified healthcare centers. So it's 5 different types of organizations all providing data to us. So, and with the goal of identifying individuals who have food insecurity and prediabetes, diabetes, and hypertension. And those individuals, once identified, get a referral and a prescription for fruits and vegetables that they can redeem at Giant, which is the only grocery store in an area of roughly 79,000 people in Ward 7 and 8 in Washington, D.C. It's for $20 a week for fruits and veg. They're able to go redeem that. They can do that for 3 months every single week as part of that. The exciting thing is starting to see the impact on those patients, from a confidence and competence in caring for themselves, starting to see improvements in clinical biomarkers like hemoglobin A1C, increase in primary care utilization, so they're getting back for their care, and decrease in avoidable utilization. So love when you're able to sort of put those pieces together, sort of start by identifying the people at highest need and then measure that impact. Another example, real quickly, and I'll stop. One of our partners in the Midwest, who's been at this for an extended period of time, manages and runs a financial opportunity center for their patients that we've helped identify that have significant risk around economic strain, financial strain. Those individuals are being enrolled in a financial opportunity counseling center, and as they go through that program, what we've been able to measure is significant impact, certainly from a clinical utilization. So more than 20% impact decreases in ED and inpatient utilization, but also from a life standpoint, able to see increases in their monthly income and in their credit scores. And so for an individual, metrics like that really matter. So hopefully that's helpful.
Extremely helpful, and thank you for that. I think the stuff you guys are doing is super impactful and awesome. Let's move on to Joe. Let's move back to Joe for a second. So Joe, you guys, the CLX Health team is sought to build a solution, as we said, to get us back to kind of life, leveraging the output of the clinical lab results to show that don't have COVID, do have COVID, have been
That's
immunized, right, or for other uses. There's a ton of private and sensitive data involved in that. So how do you guys think about, and how are you guys handling that today?
Well, I mean, so this is an interesting question, just because of the experience that the environment that we lived in pre-COVID. So as an organization, and as I described this, more of a clinical clearinghouse, we were primarily engaged with healthcare providers, health systems, and laboratories, right, and moving that data back and forth. What COVID did was create a new stakeholder, right, and that was the consumer. So we had to account for a new stakeholder, have to find a way to credential them as a user of the data and have that an accessor of the data, and be able to validate the transactions, the communication between the laboratory and that consumer, because as we all know, pop-up labs were appearing in shopping mall parking lots, right? So you have all these new environments and experiences that we had not accounted for before, and we had to start creating security around these very much Wild West type of events that were taking place in the United States. So what we did was we partnered with TransUnion as a validator of that consumer, accessing TransUnion's identity management technology, their ID Vision group, to verify who that person was when they did register through our mobile application. So once we validated who they were, identity was, and we authenticated their device against fraud, that was the first part of the transaction. The second part, certainly making sure that once that consumer is validated, giving them the opportunity to communicate with all the other stakeholders, but also having a total, from a solution set perspective, being able to identify the other pitfalls around privacy. You know, another one of the challenges in COVID was the misinformation that was going out around contact tracing and tracking, and if I use this app, will people know what I'm doing all parts of the day? And we were very sensitive to that type of experience. So we coordinated to make sure that the consumers felt like their privacy was protected, both from a data perspective and also giving them plain language information so that they understood what we were doing from a data authorization use point of view, and really playing that out across their experience in our enterprise. And really just that's the one use case, and really from engagement of the consumer to this entire process through our mobile application, to our Healthy America application, which really drove them to having a very light and simple experience which is robust with a very, what we feel to be a very thoughtful process and concern around their privacy and how critical that was. So as we built that out, and we understood that this didn't just have a testing use case, but it really did have a back to work, back to real life application. So creating a process too where an employer can have a relationship with an employee and be able to communicate the most recent test information that's come through. And we've done that successfully, creating a QR code within our application that is scannable at the point of entry for a facility, or by or for an office, or even, you know, a small business where an employer can scan the QR code. There's no information or no HIPAA protected information that goes out to anybody. It just provides a green or red, ready or not ready. And that red can be something as simple as they haven't participated within the testing protocol as been defined in the job. It doesn't at any point disclose, oh, they've tested positive or anything like that. So we have that type of application or communication of our application going out to the different stakeholders in this process, and that's since also been expanded to include travel, as we work with our partners also at Accenture in conjunction with TransUnion for travel to international jurisdictions and coordinating on that, which has also given us the opportunity to expand our lab network outside the United States. So this has been a very interesting, situation for all of us as we've identified the needs and the different opportunities in the market, both around back to work, but mostly back to real life, or creating not a no-risk environment, but really looking at it from a risk mitigation point of view to make this data not only operationable, but actionable.
That's awesome. I mean, yes, it's been exciting to work with you guys for the fact that we're using, existing proven solutions in the market to solve for a new kind of challenge, which has been fantastic. Not to mention that it has come with a bunch of twists and turns along the way, and we haven't all completely solved it, but I'm excited for the prospects of us being able to actually get back on an airplane and see people and get back to the office. So, it's exciting. Shifting gears here, back to Craig. Craig, you guys are attacking the financial pressures, facing healthcare consumers, and we know that's the number one cause of bankruptcy. Again, what data specifically are you guys leveraging to make that possible?
Sure. I just wanted to add, too, that you guys at TransUnion are helping us be using data more securely, too. You're coming out with your product that harmonizes the ID numbers across your credit, non-credit, SDOH data, which means that I only have to provide that one piece of data to you, and I can get all the information I need without exposing who that person is. So that's something that you guys are doing, and that's exciting to us. what we're doing, one of the most important things is to find out, evidence that what we're doing is impactful. Because for the first 6 years, most of the money that we've received is coming from, I call it more emotional money. People that know that people are being hurt by this financial burden of medical debt. So many people are getting into bankruptcy, or even worse, 15 million people each year are going insolvent. So we need to do research. So we do randomized controlled trials on our debt purchases. And we've got MIT, University of Chicago, UCLA, UC Berkeley collaborating with us to do studies both on wellness as it relates to abolishing debt, or even the normal thing you'd think of as economic impact. So we've been using data to do that. We use the longitudinal data, which enables us to go back in time, a snapshot of someone's credit at X period, maybe 9-10 months ago, and then every 3 months going forward, while in the middle we abolish debt. So we're going to be able to find the impact. We also want to know whether abolishing debt that's very young, maybe 6 months to a year since the discharge date or the date of service, or is it as impactful when you abolish debt that's 7 years old? Now, the 1-year-old debt costs a lot more than the 7-year-old debt, so you have to make a balancing act there. But you use data to determine that. One of the most important reasons for us using TransUnion is to use ID, which is telling us where these people are and who they are, so validating them, because about 20-some-odd% of all the forgiveness that we give, the letters come back to us. So can you believe how important it would be for us to find those people? So we use TransUnion for that. And then the basics of our business is to qualify a person for medical debt forgiveness. Now, the hospitals have done this as well as they possibly can, but unfortunately, it's an opt-in model where you have to fill out an application for charity care. What we're doing is we're using big data to determine the people that need charity care or should get charity care, and we use it by income. So we're trying to find, the income of each person. Now, we can use credit data to find that, or we can use community-based data to find that, non-credit data. So we use that. We need to find out what their poverty level is. So are they 2 times the poverty level or below? Second, we want to find out, are they insolvent? Because that's another category that we use to pick this. So we'll use credit data, and we see how much debt they have and how much assets they have, and if it's negative, they're insolvent. Now, it's not a perfect science, but that's how we use it, and it's been very effective. And that's mostly the way we use the data.
So sticking with you, Craig, on that same lines, are there challenges you see in getting access to the data? And if so, what do those look like?
Okay, unfortunately, the population that we help oftentimes do not have credit. They don't have a credit report. So in the early part of our relationship, we were only able to use credit, so we were missing maybe 40% of the people that we were helping. There was no data. Now what we're doing is we're using community-based data or non-credit data to help formulate how we can help people. We don't exactly have the ability to determine their income from any public records, but we're able to look at some averages or some medians in the areas that they live in. The other part of the data that's been difficult is finding the household size. I mean, that's been difficult because that's the way you determine your poverty level. So, we've got several ways that we're using TransUnion's data to do that. The other thing is we needed to find the people that are in hardship. to me, that's one of the biggest problems here. It's not just that people make low income, is are they in hardship? And by hardship, I mean, are they foregoing health? Are they foregoing a prescription? Are they foregoing to go to a follow-up visit? Are they not able to get to a hospital or a doctor? We want to know this stuff. So we use data for that. But we're also making sure that we find, like there is a push now at TransUnion to start developing a score for us that's going to enable us to predict hardship. And they use this model that's going to predict bankruptcy, which is very similar to hardship. So that has been in the past the harder way to get data, the harder means of getting data, and that's how we're using TransUnion's data for that.
How about moving back to Joe? Same question for you. Challenges that you guys see relative to data access?
So our perspective is a little bit different. We are the infrastructure for the data that we curate between the different stakeholders. So from a data accessibility point of view, at least for the lab data that we project results for, and our COVID solution is based on the Healthy America app, it's not so much that challenge. The challenge that we see in the market because of what COVID is doing experience-wise is we think back to 9/11 and the impact of personal privacy, what someone went through, what you were willing to give up to get on a plane and do this and do that. And as jurisdictions open up, and I'll mention the travel use case that we're working on, each jurisdiction has its own rules around privacy, how old data can be, what can it be used for, what are the limits. So as we look at this situation, it's relatively fluid, and we watch and see what the federal government here in the United States is doing, what governments in Europe are doing around use of that data, what we can reach back and manage or monitor around. So those are the challenges that we see, and they're really focused on privacy in our world, how that data can be, not so much from an accessibility point of view, but how is it used or how can it be shared after it's been accessed, and what are those use cases, and then how would those be regulated? And certainly here in the U.S., we're grateful for our partnerships with TransUnion to help navigate that with their privacy teams and the hours and hours that we spent to make sure that not only were we managing what a current experience would look like, but also identifying future states and how consumer privacy would be impacted, and really trying to account for that as well. So that's where our challenge is and what we feel that comes from.
You had to bring up privacy.
I had to bring it up.
Privacy stuff. This is what we do.
That's right.
There's a lot of it, man. Yeah, we got every regulator you could imagine looking at us. So very serious. Same. Last for you, Trevor, on this question before we get to some audience questions. Kind of what do you see in the SDOH space? With your application, Socialscape, and the clients you're working for.
Yeah.
Is it hard to access that data? What are the challenges there?
Yeah, so I'll talk about some of the good real quick. So I think when we think about public, commercial, and then our customer data, because of the relationship and partnership with TransUnion, our confidence around the commercial data, both at an aggregate and an individual level, is high. So that's not a challenge. It's part of the piece of the puzzle that works really well. On the public side, I think part of the challenge is just some of the delays. And when I think specifically related to what's going on with COVID, and we will be in, unfortunately, I think, this situation for multiple more quarters, our public data, it lags so far behind. So how do we make sure we have the most relevant, up-to-date, publicly available data, and whether that means working more with states or localities who are gathering more granular data as part of it. Clinical and claims, I think, is good. I think where one of the problems from an accessibility is, in the ideal state, you're creating a whole picture of the patient. We actually want to bring payers and providers together and think about the person as one person, not as a member, not as a patient, but as a person. So I think one of those challenges is, how do you find the right models to bring those organizations together? And then the last challenge that we probably don't talk often enough about is, how do we get the voice of the person? Again, whether we think of them as a patient, a member, a clinical trial participant, but the ability, right, to contribute to this process themselves. And in some respect, I think about it, Jim, like a credit score, right? Your opportunity, right, to engage, to weigh in, right, in your own credit score. Similar way, like, engage as part of that. So how do you identify that I'm not just at risk, but I have a social need around housing, right? Or that I'm participating in a program now that is allowing me, right, to mitigate some of that risk. So I think the challenges of thinking about how do we pull the patient or person into that model is something that we all should be thinking about.
Yes, agreed. And as we evolve, let's hope we can get to that kind of simplicity of not the credit data simple, but that we can all engage in managing that and paying attention, have the means to do that. So as we wrap this up, I want to spend some time and take some questions. But first, let me thank you guys for kind of sharing your stories and sharing this information with the audience today. I think we've got a number of questions we can get to. You know, TransUnion, we're thinking about this every day. As Craig mentioned, we're spending an inordinate amount of capital and resources to ensure that our data is curated, that it links across, that we have what's called the TransUnion Perm ID, that links all this data and a key ID aspect across, so that we can get a more holistic view of an individual and tie those back to community, and that we spend, as Joe pointed out, an inordinate amount of time on information security and privacy and how the different regulatory bodies impact kind of decisions we have to make and protections we have to place, certainly keeping forefront the individual consumer in mind. This is ultimately their data, right, in many respects, and or, you know, generated from a visit that they had, and then HIPAA comes into play and all the other regulations that we have. So spend a lot of time thinking about that, and we'll continue to do so for the different use cases that we come up with. But with that, I want to shift gears here and get a couple of questions that have been posed from the audience. Starting with Craig. Greg had asked, Greg from Pituity is asking, you know, how do you guys determine which debt to purchase and retire? And then how could a hospital or medical group connect with you to discuss your RIP solution?
That's a great question. Thank you very much, Greg. The way that we determine which debt to buy depends a lot on the hospital or the medical group. We'd be willing to go back 7 to 10 years to determine which accounts we should buy, especially if, you know, a lot of times these accounts that have been decided, you put them on the shelf as a hospital or medical group, that you're not going to collect on them anymore, but the patient still thinks they owe the money. So it depends on the hospital. Some hospitals will donate a certain amount of debt from, say, 5 years and on. But if your question is more about how do we determine, you know, from a numbers perspective, which to buy, it really comes down to that charitable class that we identify. So we get a feed from the hospital or the doctor's group, and we put it through our TransUnion scrub, and it tells us which ones qualify by income, which ones qualify for insolvency, and which ones qualify for another category I didn't bring up. But if their debt is equal to 5% or more of their gross income, they also qualify. So we'll only buy qualified debt, and then we'll just determine the fair market value of that debt as if we were a real for-profit debt buyer, but just in this case, we're just going to abolish it all and not collect on it at all. But we want to make sure you're getting the best possible price. The second part is, how do you get in touch with us? You can call me directly at 914-565-9363, or you could go to our website, and there's a way to just ask us any question, but it's at www.ripmedicaldebt.org. And thanks so much for your question.
Thanks, Craig. Next one is from Truefish Consulting. It's a Trenner. Pose this to you. How aware are healthcare organizations of public sources of data versus trying to capture it for themselves for purposes of SDOH?
I think the majority of both system, so provider organizations and certainly plans, are well aware of many public data sources and may even have started to pull those in. I think the challenges associated with that robust, available, and free data is that it is almost always on different refresh cycles. So even from the same federal or state organization, different refresh cycles, it's represented at different parcel sizes. And so when you start to combine that data, like sometimes it's at a census block, sometimes it's at a zip code, sometimes it is at a county level. And so how you normalize and manage that, again, in a scientific way, it takes a tremendous amount of efforts. And the other piece I would say is, even though they're aware of the sources, it's not just about sort of the sources, it's how do you sift through the individual data elements and what those elements tell you, about what insight do they give you. Again, that's full-time jobs for multiple people. And I think what we have found is, organizations, do they have the size, willingness, bandwidth, right? Do they have an extra team that's sitting on the sidelines that can start to do this work, right, themselves and own it? Or are there better ways and partners to be able to bring in so that you can focus, if you're a provider organization, you can focus on, your data and your responsibilities around care delivery, I would say.
Following up on that, just for me, what percentage do you think are still using the providers themselves, be it in a home care setting, in the extenders and home health kind of aspects, and or a physician? We always talk about just asking one more question in the ER as you're talking to that patient, and that one question's been asked 20 more times. So now they're getting burnout. Like, how prevalent do you see that as a challenge for data capture?
I think it's huge. So one is because we continue, understandably, right, we want to leverage the patient as a trusted resource of that information, but it means that we're asking them appropriately about domestic violence issues, right? We're asking them a PHQ-9, right? So 9 questions potentially, so two screening about depression as part of that. And so that process and those screens start to add up significantly. And so I do think that there's real issue. The other part, or the challenges, is just the person power associated with having to do that screening. It's not that it's a valuable tool, but in general, it's a one-time event. It's time sensitive based on what's going on with that person around them. And most of the time, organizations don't have background information to be able to validate, verify, or dive deeper on a person's response, right? So if I'm asking somebody about food insecurity, but I don't have any information about where they live and the resources that they have available to them, whether that's SNAP retailers or how close a grocery store is or anything like that to them, it makes it hard for me to do something valuable with that information. So I believe that screening is important. I don't think it is a panacea, and it is a replacement for having access to robust insights that you could use to, one, proactively decide who you screen, and two, when you have those opportunities to have those precious conversations, you can take full advantage of every one of those events.
Joe, I got a question for you from Kenny, Greater Baltimore Medical Center, and said, for your application to work, you'll need exposure. So how do you plan on expanding or popularizing your Healthy America product?
Marketing is always a great question, right? So what we've been doing to get set up is we've done a couple things. We've partnered on the provider side with an organization called Availity that will drive the provider side of access to our platform, and there are 1 million+ providers across the country. From a Healthy America perspective, that integrates communication between the healthcare provider and the consumer. On the consumer side, we're actively working with large enterprise employers, 25,000, 50,000 and above, for use of the Healthy America platform and system. Some of those larger employers like to have their own experience. So what we're coordinating on is branded by, powered by type of Healthy America solutions, because they may have, for instance, Anheuser-Busch, as an example, has an employee app that they communicate with their employees on, and for different services and around their entire business. So building this experience within that experience has been one of the opportunities that we've been building out. So that all comes from from a large enterprise user perspective. That's where we're focused on today. As this graduates into other use cases, it will also have standalone functions. For instance, I mentioned travel. One of the components in and around our travel opportunity with our partners at Accenture and of course TransUnion is making sure that the consumer always has access, not only the ability to travel and have credentialed documents, but also has access to those documents after that travel event is done. So being able to travel and have those documents, and also have a most recent test that they can reference, have access to, and share outside that travel use case requires use of Healthy America. So as we build out that solution with our partner airlines that we're coordinating with, then that all comes full circle.
And you just a couple clarifying questions. This is available on Apple and Android and in the stores today. Is that correct?
Correct. That's correct. It's available in both stores.
And it is there was a question about, is this actually functioning today, or is this a future state thing? And the answer is
the application, as I said, it's available in the stores. So it is a working solution. It also has some additional features based on the customer experience, or the client or the buyer, if you will. So we have a health plan buyer that has asked for additional functions like a symptom checker, in addition to an employer group symptom checking, in addition to managing and monitoring COVID test results, and being able to push all that information together into one stream. So as we try to be as solution focused as possible, there are also unique use cases that make us think of pieces of an application that we hadn't considered before. For instance, we have a client that we're coordinating with right now that is asking us to integrate, from a health plan perspective, telemedicine on a positive COVID test, so that now it would queue up once a positive COVID test comes in, it would actually move that consumer into a virtual waiting room to be able to manage and monitor that positive event moving forward. So keeping everything tight from a care coordination point of view for that member on behalf of the health plan, and also having a partner health system of the health plan manage that individual so that they don't put others at risk. So these are all as we build out and learn from what the market needs, and we adjust and add features to our solution.
Awesome. Well, we are right at the top of the hour and time, and I want to thank everybody again. I want to thank Becker's, all my panelists and friends and colleagues that are, and certainly all the people who participated. With that, I'm going to turn it back over to Ayla to close things up.
Thanks, Jen. Yeah, that is all the time that we have for today. But once again, I want to thank Craig, Joe, and Dr. Williams for sharing their insights, and TransUnion for sponsoring today's roundtable. Please enjoy the rest of your day, and we look forward to having you join us for future Becker's events.